maternal sepsis. Sepsis. You know, when it occurs in a small way, we call it an infection. Okay? But when it is so overwhelming, when the infection becomes so overwhelming, then we call it sepsis. Okay? So that is sepsis. So maternal sepsis is a life-threatening condition defined as organ dysfunction. This is the latest definition of sepsis. Organ dysfunction. You should have an organ, any one organ dysfunction resulting from infection during pregnancy, of course, childbirth, postpartum, and post-abortal, so on. Okay? So that is maternal sepsis. So remember, the most important thing in the definition today is that there's an organ dysfunction. Now, can I ask, we all can start from one end. Dr. Kameswari, what is septic shock then?
It is one subsect of sepsis requiring vasopressors to maintain a MAP of more than 65 and a lactate of more than 2 millimoles and without hypovolemia. So this is septic shock. Once upon a time, it was thought to be acute circulatory failure, but now it has more clearer definitions and endpoints.
Yeah. Thank you, Dr. Kameswari. So, in very simple terms, it's intractable hypotension in sepsis. Okay, intractable hypotension. But she used a few things, and every word of what she said is important. It is defined as sepsis. You have given the initial fluid resuscitation, and after that, you have had to use vasopressors to maintain a mean arterial pressure of 65 millimeters of mercury. We don't say BP per se by itself because MAP is more sensitive. And then a serum lactate. Serum, always we talk about a serum lactate more than 4, right? But more than 2 millimoles itself start thinking. So this is what the Surviving Sepsis Campaign 3 has told us. In simple words, whenever you've got a patient with sepsis, after the initial fluid load, which we'll be talking about now, if the BP does not pick up and you're required to give her vasopressors, do you understand? That is septic shock. She is in septic shock. Dr. Sunil, can I just ask you one word? What is the importance of MAP and the regular hypertension, like systolic and the diastolic?
That's a good question. Basically, mean arterial pressure is...
Can you hold your mic a little closer?
Yeah, MAP is always better than systolic blood pressure because mean diastolic blood pressure is the one that regulates the tissue perfusion. And basically, it can be calculated as diastolic pressure into 2 divided by 3 actually, basically. So it is the pressure that dictates or delivers the tissue perfusion. It's not the systolic pressure. So always we take as mean arterial pressure as the pressure when we are titrating or when we are delivering resuscitation in a parturient with shock.
Yeah. So it dictates tissue perfusion. He very clearly has told you all, it is diastolic plus 1/3 pulse pressure. It is much more significant rather than just looking at a systolic or a diastolic BP, okay? Right. Thank you so much, doctor. What are the commonest microorganisms that...
Sareena, can I just add that importance of MAP is even outside of sepsis. So any shock, even if it is hemorrhagic shock, we have to learn to kind of react to the MAP and not react to a systolic or diastolic.
Even in preeclampsia, now we talk more about MAP. In any hemorrhagic shock we talk about, it's also in septic shock. So MAP is more important than the regular BPs. Okay, thank you, Ma. So what are the commonest microorganisms that we normally encounter? Dr. Nuzhat, can you take that?
I got the easy one. E. coli is the most common, followed by Streptococcus. Then you have Proteus, you have Klebsiella. Any staph, any organism can cause, but these are the commonest ones that you would come across. E. coli followed by Streptococcus is the most common infections that we find in pregnancy.
Yeah, that's true. So E. coli is the commonest. That is why, what type of sepsis do you normally come across in pregnancy? Like pyelonephritis?
It can be
chorioamnionitis.
Depending on the period of gestation. In the antenatal period, it might be chorioamnionitis. In the postpartum period, it might be mastitis or breast, or it might be urinary tract infection, or vaginitis, chorioamnionitis, endometritis.
So it starts off somewhere, okay? It starts off and then it becomes generalized. Do you understand? So, but what is very important to remember that E. coli is a commonest. And of course, as she said, Klebsiella, Proteus, etc. responsible for the gram-negative shock. And very, very commonly we come across a streptococcus, especially, when you get necrotizing fasciitis, etc. It is a streptococcus hemolyticus, which is very important, very fulminant infection. Okay. Then as she said, most of the times it's multiple organisms put together. It's not just a single organism. So enterococci, the Clostridium, and so on and so forth. But what are the non-infectious? See, many times patient is in shock. You know what I mean? You go there, you find patient having cold and clammy extremities, you find there's hypotension, but we have never thought of sepsis because we thought of an amniotic fluid or whatever. So what are the non-infectious conditions, Dr. Uma, that can mimic sepsis and, might take you through the wrong tract?
So actually any inflammatory condition that causes an acute inflammatory response can mimic sepsis. So that could be, as you said, an amniotic fluid embolism. It could be, a failure from any chronic condition. I mean, acute failure like liver failure, acute fatty liver of pregnancy, pulmonary embolism. All of that, the clinical presentation can be the same.
Yeah, that's it. So many times we never think of sepsis and suddenly we realize, could this be a septic shock? And then we go on to doing some of the biomarkers and it might tell us.
Importantly, we need to remember that postpartum thyroiditis also can mimic any of those features of septic shock.
Dr. Sunil, just keep your...
Thyroiditis, like thyrotoxicosis also can have this thing, and not to forget trauma, burns and acute pancreatitis, which can also mimic septic shock. Yeah.
So we will never know that it is septic shock until you think of it. So you've got to think there are many conditions which can mimic it. And and we will never know what the diagnosis is. Suddenly we'll realize, oh, could this be sepsis? She's got an ARDS, could this be sepsis? Like that, we start thinking. So remember, so many things can mimic sepsis actually.
So more importantly, whenever you have any shock, resuscitate first, ask later. That should be the norm.
Yeah, very good.
Yeah.
Do whatever you have to. You know what? If you find hypertension, treat the hypertension. If you got decreased oxygen saturation, give her oxygen. Like that. You just treat symptomatically and then later. Yeah, I fully agree with you. Most of the times, that's how you should treat any patient who has collapsed. So what are the obstetric risk factors for sepsis? Dr. Kameswari, you'd like to take that?
Yeah. Many things actually. If you look at obstetrics, simple procedures like even cerclages, abortions, septic abortions especially, PROMs, puerperal sepsis, endometritis, or any invasive procedure like amniocentesis, CVS, you name it, any procedure is at risk of causing pregnancy-related sepsis.
Yeah. So it's very important that anything that you do in obstetrics, you must be careful that you do it under all aseptic conditions. There's no question about it. From washing hands to donning your gloves, everything should be done. See, all that has been illustrated there is all obstetric procedures. So if you don't do it the right way, if you don't maintain your normal labor hygiene, etc., you will land in trouble, okay? Even your PVs, please restrict your PVs. Do everything which will reduce sepsis, okay?
I think more than 5 should be avoided. Vaginal examinations in labor, there's a figure quoted, more than 5.
Oh, that is the number of PVs they say. But when we look at 5 in our hospital, I think it is too much actually. I get very angry with the PGs because they should not be doing too many PVs. It's very, very important, okay? Don't keep on. And whenever you do it, you must wash your hands and don the gloves. So the comorbidities which can make sepsis worse. Dr. Kameswari, you'd like to take that?
Diabetes, anemia, any connective tissue disorders, immunosuppressed conditions, if they're on steroids or HCQs, low socioeconomic status, obesity, and these days even COVID, we have to name it.
Makes the whole thing bad, isn't it?
More importantly, not to forget post-prenectomy patients, sickle cell disease and post-prenectomy patients, because they are immunocompromised as such.
Dr. Sunil, we want your mic.
Post-splenectomy patient or sickle cell disease.
Post-splenectomy patients.
Okay, fine. Post-splenectomy patients. So what is the main difference between understanding of sepsis before 2016? Dr. Uma, What did we think of as sepsis before 2016? And 2016 gave us a different perspective, isn't it?
Yeah, so I think before 2016, the SIRS or systemic inflammatory response syndrome was what one thought of, and so the criteria was that of SIRS was in place. In 2016, there was a consensus meeting where they said that that is a different entity, and it's only infection that results in an inflammatory response should be labeled as sepsis, and therefore there were a set of criteria. So the SIRS criteria is what you have projected here,
yeah.
And this is no longer
do we say this, okay?
Yeah.
As she said rightly, formerly we used to say SIRS, it requires at least 2 of the following: temperature of so much, heart rate, respiratory rate, the partial arterial oxygen and carbon dioxide tension of less than 32, WBC count less or more than 10, all these, and we said any 2, if the SIRS is there, then we say that was sepsis. But now the concept has changed, okay? But we all believe that sepsis begins with the inflammation response that is directed against microbes, which could be producing endotoxins or exotoxins. Everything is there. But then later on there is a cytokine storm, everything is there. But we do not take this as a criteria for us to say it is sepsis. It begins with this, okay? It begins with this. So what was the change that came, yes, Dr. Sunil, I think you would be wiser to tell us, what was the change that came after 2016?
The paradigm shift that happened between before 2016 and after 2016 is, as rightly said by Dr. Uma, inflammatory parameters versus organ dysfunction. So the major change that happened in 2016 was organ dysfunction as a specific way to define sepsis and intensity of sepsis. And that's how it led to the formation of sepsis organ, sequential organ functional score, and so on and so forth. So basically, it is organ dysfunction which was the major paradigm shift that happened in 2016.
Yeah. So actually that is it. The definition of sepsis was updated in 2016 following the publication of the 3rd International Consensus Definition. And basically what I told in the first slide, basically all elements of sepsis, that is infection, the host response, but organ dysfunction. You should get an organ dysfunction for you to say that it is sepsis. And the latter was given more importance, and thus came the SOFA score. Okay. Now, Dr. Sunil will tell us more about the score. Dr.
Yeah, basically,
Sunil?
sequential organ functional assessment, basically it takes into account 6 organs: the cardiovascular system, the respiratory system, the neurological system, the kidneys, the liver, the platelets, and urine output. So basically, you score every organ from 0 to 4. 0 is everything is normal, like PF ratios of more than 400 and bilirubin of less than 1.2, platelets of more than 1.5, urine output more than 200 ml per, at least more than 100 ml, 0.5 ml per kg per hour, so on and so forth. So as the dysfunction increases, a scoring is given like 1, 2, 3, and 4. Any score more than 2 is considered to be significant because it are directly proportional to the mental morbidity, and if you don't treat adequately, it can result in mortality. But I must tell you that based on the SOFA score, the Society of Medicine, Obstetric Medicine, Australia and New Zealand, they modified obstetric SOFA. So the SOFA, all these 4 parameters, like 6 parameters, they have just concised to 0, 1, 2 instead of 0, 1, 2, 3, 4. 0, 1, 2, because if you see in pregnancy, if you look at the renal system, we know that creatinine more than any rise more than 0.2 milligrams is considered to be significant. Like it can be 0.5 to 0.8 also can be significant. So if you look at this conventional SOFA score, you can go up to creatinine of more than 5 to reach a score of 4. Whereas the obstetric SOFA, anything more than 1.4 is given the highest score. Like that, you have the scoring system in each system.
Yeah. See, as you rightly said, see the score of 4 shows a PA, that is this is the oxygen, arterial oxygen tension divided by the fraction of the inspired oxygen. If it is less than 100, it is a score of 4. You saw that? And then look at the coagulation when you got a platelet count less than 20,000, score of 4. Bilirubin more than 12. When it requires vasopressor, especially NORAD, The CNA, that is the Glasgow coma scoring, less than 6. Anything 15 is the best. Anything less than 6 comes under score 4. And the creat, which she told you just now, more than 5. So you see that some organ is involved. You understand? When you see any of these organ dysfunction, already when the score comes under this, it's already 4. It's more than 2. So it tells you that it is bad in the scale, okay? So, Dr. Sunil, I want you to tell us this. Yeah. What is the importance of the quick SOFA score?
If you look at the elaborate SOFA score, there are so many parameters, 0 to 4, it's like confusing. And many times the nurse may not be charting all the parameters or may not be savvy to chart all the parameters, and you may sometimes miss the intensity of sepsis. Hence, when they have analyzed the different randomized studies and trials, they came out with Q-SOFA, that is quick SOFA score, wherein they just took into account 3 parameters: the systolic blood pressure, the respiratory rate, and altered mentation, the sensorium. So any respiratory rate more than 25, systolic blood pressure of less than 90 millimeters mercury, and and altered mental status is considered, any like score of 2 is considered to be significant and should be treated on an urgent basis or emergent basis to prevent further deterioration. So
doesn't require any blood test.
So basically that is a quick SOFA, and what I said is also a maternal Q SOFA. It doesn't require blood test, yes. It's just a clinical assessment.
Yeah, it's very much, but most importantly, it is, as he said, it's only a clinical assessment, but it tells you, gives a very bad prognosis. These are the patients, if it is more than 2 she requires, it's a poor outcome. So just by seeing tachypnea, pick up tachypnea. Do you understand? When you see a patient whom you have operated on, and when you find that in the 3rd or 4th day when you go, she's tachypnic, that's the first sign for you to pick up. Then when you find that she's not so well oriented, even though she's a little drowsy, remember, you will have to, that is a clinician in you, okay? And then of course when you find hypertension.
Yeah.
Yes. Yes.
Can I just add, Sareena, that if you, so basically these are ways, as Dr. Sunil said, it's purely clinical. So this woman can be in the ward, and this helps us escalate care or transfer based on these findings. And therefore, if you club this with the MEOS chart, where you can actually pick up that tachypnea and you have a color coding where you know the moment the respiratory rate is going up.
Correct.
Or even if you think this is just a UTI, it's a post-operative UTI or post-section UTI, but you find that the mother is tachypnic or she's a little disoriented. We don't put it down to lack of sleep or she's fed the baby, whatever. It's better to escalate, find out that actually she's okay, and rather than wait till she's is throwing a temperature of 103, becoming hypotensive, getting into organ dysfunction, and then needing care. I think that is what we are trying to pick up with these.
Absolutely.
Am I right?
The most important thing, as Dr. Sareena also has emphasized, the most subtle parameter, physiological parameter, is respiratory rate. Even if you look at the MEOS chart, the topmost parameter is the respiratory rate. So tachypnea should never be taken lightly. If at all you want to diagnose psychogenic hyperventilation, rule out all other causes before diagnosing psychogenic. So tachypnea is a very, very subtle sign, more significant, more important than blood pressure and tachycardia, like even the pulse rate. And by the time the patient goes into altered mentation, we are almost missing the bus.
Yeah, we are almost losing the patient. You're almost losing the patient. Please remember that this, though it is a quick SOFA score, it's a clinical judgment, but when you find a patient tachypnic and little drowsy, beware, you may be losing your patient. Already time is gone. I remember, as you said just now, I remember once, when I was going on post-op rounds, I picked up a person just with tachypnea, and then I wrote down in my notes tachypnic, and I immediately stepped up the antibiotics. I did not wait, and I send for the counts. For me, counts are very, very important. Your total count, differential count, very, very, that is almost like a bedside test, which you can do every day. You will know whether she is worsening or becoming better or improving or not. Do you understand? So I always ask for the counts, which is very important, and then immediately stepped up. You won't believe, by evening her tachypnea settled, and I knew I caught it at the right time. So what I'm trying to tell you is, try to be more clinical in your judgment rather than waiting for labs and other things. So
Dr.
what is
Sareena,
the change in... Yes,
can I add in? The main problem that occurs is we are not using an automated vitals monitor. So if you take a look at the recordings that nurses do, it will always be written 72, 75, and 110, 80, and you don't have a respiratory rate, you don't have an SpO2. So we also, I mean, as the admin part of the institutional process that we have to give them an automated BP apparatus where they would be able to pick up, pulse rate, SpO2, mean arterial pressure, kind of a equipment, a small one which can be given to all the nurses. So I think one of the changes that has to be brought about when we talk about early warning systems is an automated BP apparatus or a vitals monitor.
But I will say, as Dr. Uma was saying, have a chart. Monitor your post-operative patients hourly. Please do that. You can pick up things like this. You can pick up a hypotension, hypovolemia. You can pick up sepsis, everything you can do. But for that, you must monitor. And if you all are not doing it, please do it from today. Every post-op patient should have an hourly BP output, hourly BP, pulse, temperature, respiration, etc., etc. If you don't have the Muse chart, get one downloaded and do it. So that they should be monitored till next morning. And then next morning, filter. Maybe you have done about 20 cases. Okay, now 18 of them are okay, but 2 of them required to be monitored. Then keep them on in your HDU and monitor the 2. The rest can be ignored. You understand? But when will you pick them up? Only if you monitor. If you don't do a pulse, if you don't check a BP, if you don't check the respiratory rate, you miss out on all the valuable early warning signs. Okay? Dr. Nuzhat, what is the change that came in 2018?
In 2016, we had a protocol which was given, I think Dr. Sunil will add to it, wherein we had 1 hour what we were supposed to do, the bundle, and then the first 3 hours and first 6 hours. They had very specific endpoints and timed manner of testing. Then in 2018, there were few important studies that came up which said that we don't need to be so stringent about doing testing so often or with the endpoints, and they were made a little bit less, right, Dr. Sunil?
See, basically, our 3 bundle was made into our 1 bundle.
Yeah.
Like you have a golden hour in trauma, golden hour in cardiac, golden hour in neuro. Similarly, in sepsis, maternal sepsis, you have golden hour of resuscitation. And that 3 hours and 6 hours became 1 hour.
Yeah.
And the Panchamantra, or 5 things that are very important in our first hour is obtain lactates, send blood cultures, give antibiotic, start fluid resuscitation. Unlike non-pregnant, in pregnancy, you just leave it about 20-25 ml per kg per hour, crystalloid, balance all solution. And then importantly, low threshold to start vasopressors. Noradrenaline is the vasopressor of choice. And if necessary, start vasopressin also. So again, I repeat that our one bundle encompasses like once you have Q-SOFA, metal Q-SOFA identified, then don't wait. Just shift the patient directly to HDU or intensive care unit and start, send lactates, that is blood gases. Second thing is send blood cultures. Start wide spectrum antibiotic, empirical antibiotic, depending on the probable source of sepsis. And fourth one is to start fluid resuscitation, crystalloid resuscitation. And while you are giving fluid, if you're not able to maintain a MAP of 65 and above, you need to start a vasopressor, and the vasopressor of choice is noradrenaline. And if the noradrenaline is also not raising the blood pressure, like if it is going beyond 6 ml or 7 ml double strength, when I say double strength, it's 4 ampoules in 50 ml syringe, then you start vasopressin, 20 units in 50 ml, start at 2 to 3 ml. So basically this all has to be done in, preferably should be done in 1 hour, 1 to 2 hours, yes.
So that was a big shift which happened in 2018 after the Surviving Sepsis campaign. For initially we were talking about when after the first and the second Surviving Sepsis campaign, we were talking about the 6 hours bundle, the 3 hours bundle and so on. Everything shifted to the first hour now. That is called the first golden hour. And as he said, the 5 mantras, all of you must remember these 5 things. Okay, immediately send for the lactate. Send for the lactate. Okay, when it is more than 2 itself, your problem is started. And send for blood cultures. These are 2 things which you will send. And there are 3 things which you will give. One is start on, this is the time you should be giving your antibiotics. Broad spectrum antibiotics, go for the kill. Go for the kill. Now it's not the time for you to start on ampicillin, moxicillin and so on.
Hit hard, hit fast.
Beat very hard. Okay, that is the way that you will be able to get her to survive that episode. Then before you start this, you already sent for culture. So what you do is, from one vein, you take the blood for culture, and then from the other, you give the antibiotic. As simple as that. Supposing it depends on what sepsis it is, okay? When it enters the bloodstream, then it becomes septicemia, okay? You understood what all is happening? First, there is a sepsis. Now, for example, let's imagine when you have done, it's an obstetric sepsis, and through your repeated 20 PVs you have done, and she's got the sepsis. So it goes into the uterus, so it becomes endometritis. Then it goes to the tubes and ovaries, okay? Then you get a tube ovarian mass or an abscess or whatever. Then later it becomes a pelvic peritonitis, then it becomes a general peritonitis. After that, what happens? It enters the bloodstream. Then we call it septicemia. Then she goes in for intractable hypotension, and we call it septic shock. Then it goes in for multi-organ failure. You understand? So there are a lot of stages before you can actually attack it. And why shouldn't we attack it? So now you know the sequence of events which goes into going for the MODS, for the organ dysfunction. Okay? So that is a time.
Again, I must tell you that if you are not able to do arterial blood gas, please do not bother. Don't get perturbed. Venous lactate also is like easy. Just when you take a venous sample, measure lactate in venous sample. That also is okay for us.
You know what he meant? Normally from the peripheral vessels, we get the venous sample, okay? That is enough for the lactate. You don't have to go for the arterial. Like when we do the ABG, you have to go for the artery. You understand? That you don't have to do, even the venous sample is fine. And then immediately start the patient on fluids. Look at this. And it is crystalloid. That is normal saline and ringer lactate. And as you give the fluids, if in the early stages of shock, the hypotension might get corrected. Do you understand? If in spite of that, or if you find the lactate is already more than 4 millimoles, see from 2 it has become 4, then you'll have to start on your vasopressors. So there is, remember this 5, let that be your take home today, okay?
Yeah. One more thing, you just mentioned about fluid. Yes, earlier 2016 and 2008, they emphasized both use of ringer lactate as well as normal saline as the fluid of choice. But the recent guidelines, they have eliminated normal saline because of most of these patients, they go into hypoperfusion, renal ischemia, and oliguria, and saline can cause hypernatremic and hyperchloremic metabolic acidosis. So either ringer lactate or balanced salt solution. There is no role of gelofusine like Hemaxil or starch in acute resuscitation.
Yeah, don't give colloids, okay? The starch and all that is totally out. You will have to give crystalloids. I too wanted to say that. I wanted to ask you, what is this balanced salt which you said?
Basically, if you look at the osmolarity of the plasma, the osmolarity is predominantly regulated by sodium, cations, potassium, and sugars and urea, which are the major sources of solutes in the plasma. And if you look at the normal plasma osmolarity or serum osmolarity is about 295 milliosmoles. And the fluid that comes very close to this plasma is normal saline, which is about 280 to 290 milliosmoles. But importantly, normal saline contains only sodium and chloride. Ringer lactate osmolarity is 280 milliosmoles. So relatively little hypoosmolar compared to serum osmolarity. And importantly, it does not have all the ions that are present in the plasma, like potassium is 4 to 4.5 in humans, whereas in ringer lactate it is about 4 millimoles in 1 liter. And you have lactate of 21 in ringer lactate, whereas in human body is about bicarbonate. So basically all the cations and ions are not same in ringer lactate or saline. So balanced salt solution like Cabalite or any of those commercially available solution, nil conflict of interest when I'm mentioning this trade name, but they match with the plasma solutions. Like cations and anions which are present in plasma, they match with that. So basically they are isoosmolars and they replenish the ions as required, as necessary.
And what's the trade name you said?
There is a Physiomax, Cabalite, Plasmalite. The only difference is ringer lactate costs about 19 rupees and Plasmalite costs about 180 rupees.
Plasmalite you said, is it?
Yeah, Plasmalite or Cabalite.
Okay, fine. So we'll move on to a few case scenarios, okay? Everything is a genuine case. Let's go to the first case. She's a second gravida with multiple pregnancy. She underwent a cesarean section, okay? In a very well-equipped hospital for premature rupture of membranes of 5 days duration. For 5 days she was leaking. Okay, and then she underwent a cesarean section. This is all the information available to me. Next day she developed postoperative pyrexia, tachycardia. That was the first thing, okay? So she was febrile the next day. Normally sepsis takes about 3 to 4 days. But this already she was in a bad state. Do you understand? So then she develops, on the third day she develops abdominal distension and oliguria. So already you started seeing some organ dysfunction, okay? Antibiotics were escalated, blood transfusion was administered. I do not know why. They have not given any values, no investigations, nothing was there. She was referred on the 4th day when she developed hypotension in that institution. Now you all understand even better, right? So she developed hypotension so the next day she developed fever. The day after that, abdominal distension is a very bad thing, okay? Remember, a person whom you expect to see a scaphoid abdomen after the post-operative day, when you find that abdominal distension, yeah, we might think this is a paralytic ileus, but beware of the distension, okay? And then she has developed oliguria and then a hypotension. Then at the referral center, she was referred to some center. It was observed that the woman was already in septic shock, because we all know she's in hypotension. And then the notes say there was extensive necrotizing fasciitis, which they have explored, and then they saw the uterine wound dehiscence. That means they have done a laparotomy. Then they found a uterine wound dehiscence, and then the notes say abdominal toileting done and uterine wound was closed. And then the patient was put on the ventilator and had supportive measures, but she died on the 6th post-operative day. So let us just think a little about this. Anybody would like to take this case on? Dr. Uma, you'd like to take that?
Well, I can.
What are the rights? What are the wrongs?
So I think, first of all, somebody who's had PROM for more than 48 hours, we are, aware that she's at increased risk of infection.
Yes.
There's no information on whether it was an elective section or there was an attempt at labor. We don't know. If there was, that could have compounded the chance of infection. When she's developed postoperative pyrexia and tachycardia, clearly that is where intervention should have happened to prevent the further deterioration.
But Uma, I'm just asking, would you have given some antibiotics at this stage?
No, so somebody with a PROM of more than 5 days when we are operating, she is someone in whom you won't stop with a prophylactic antibiotic.
Yeah, exactly.
So you probably need to consider giving her an antibiotic, at least 2 doses post-section, and then see what is happening. Within 24 hours, if she is pyrexial and tachycardic, I'm already concerned that she's going in for sepsis at that point. And therefore, more evaluation would have to be done. You would want to send off her blood for cultures.
Lactate.
Of course, the lactate and appropriate fluid resuscitation and a complete blood count and to know what is happening to her, and send off the blood cultures. And then appropriately escalate the antibiotic, as was discussed in the first hour bundle, and then follow her up more closely. I think
she's
that
a multiple pregnancy, there's a risk factor already there. How many weeks was she?
This is all the information I've got.
More importantly, when you
the very fact they waited for 5 days tells you that she must have been not term. Yes.
Yeah, 5 days.
That's why they must have been buying time.
5 days.
That's what I got from understanding.
Yeah, with 5 days of PRM, if you're going to a hospital, first thing is you do a vaginal swab and send a baseline TLCs, and appropriately escalate the antibiotic at 0 day only, 0 time, 0 hour.
0 hour.
So that is important. And second thing is, when she developed, like she had if you look at the Q sofa or metal sofa, on the next day itself she was flagging the signs, tachycardia and pyrexia. And probably waiting for third day to escalate the antibiotic also is something which is a little
very late.
And blood transfusion, because blood transfusion itself is a risk factor for infection. So that also we need to take into cognizance. And probably, I would say, suboptimal treatment, inadequate treatment, delayed treatment.
Yeah, exactly. That's what I too told myself. We could have actually, this was very much a preventable cause of death if we had done the right things at the right time. And then when she went into oliguria, what do you think it was? She was already gone in for?
Hypertension.
Yeah,
Organ
she's already
dysfunction.
gone in for the next organ. So, yeah.
Dr. Sareena, I mean, one important thing that we can do when we have cases like that is to send the membranes for culture also. So if we can do that, then we will have an antibiotic which is different or whatever.
Yes, yes.
And in the post-op period, you have risk factor. So if she develops pyrexia or distension, doing an ultrasound abdomen bedside then and there, and adding on an aminoglycoside may be much more, first thought, first time as you are doing it. She must already have been.
No, even a vaginal swab could have been sent.
Yes,
for
so
culture.
at the beginning. So you
a high vaginal swab, not a low one, a high vaginal swab. Low one will be contaminated. Okay?
One more thing that happens at the head end, I must tell you that like majority of the time the cesarean sections we do it under spinal anesthesia. And I would say about 20% of women with spinal, they develop some sort of hypotension. And the classical doses of vasopressors that we need to treat hypotension is about 6 milligrams of ephedrine or about 50 mg of phenylephrine. But if the requirement is beyond that, in a straightforward spinal, then suspect, is it sepsis? Yes, 5 days PRM, or is it occult cardiovascular disease? So you need to trigger off at that point of time. In fact, I recall several cases who came like this, who necessitated like almost 30 minutes of ephedrine intraoperatively, and we sent the cultures, lactate, but everything was positive. We sent the placental bed cotyledon, that is the best source of culturing, like membranes as well as the base of the placenta. You send it for culture. So, and the neonatal blood culture. So most of them, if the patient is having infection, then all are positives. So
absolutely.
that is another thing that you
And
need to
I'll say normally we define sepsis as a high cardiac output, low systemic vascular resistance, but concomitantly they're going for pulmonary hypertension and you'll have myocardial depression. Remember that.
The clinically,
so that is the warm phase of sepsis.
Clinically, hypotension with warm peripheries is septic shock. Hypotension with cold peripheries is cardiogenic or a hemorrhagic shock.
And later on, she goes in for oliguria and peripheral vasoconstriction. That is the cold phase, bad. So she was already bad then. Do you understand? The cold phase and bad. That first is the warm phase, second is the cold phase. So that actually oliguria tells you it's very bad and she's going in for, bad outcome. And they also say that with every organ that is affected, 15 to 20% there is a drop in the survival, which is very high. So you should try and see whatever, where is the organ, which is the organ that is affected, what should you do. Apparently this must have been hypovolemia at that time, and with the little fluid correction, etc., she may have come round. Okay? And then this, what have you got to say about this? There was extensive necrotizing fasciitis. Anybody wants to take this on?
See, basically when you have necrotizing fasciitis, it is gram-positive and gram-negative sepsis, both. And many a times, this is where the antibiotic cover is very important. When you have a case like this, yes, go for the best. You need to give gram-positive cover like vancomycin and clindamycin and probably piperacillin tazobactam or meropenem, so that you cover the gram-positive, gram-negative, as well as you take care of even the anaerobes. Very, very important. And probably in this case, abdominal, like when the wound dehiscence is there, I don't know the nature of wound dehiscence, and was it just simple dehiscence? Had it been a grossly dehisced wound and a false burning discharge, then probably sacrificing the uterus, probably, I don't know, in retrospect, hysterectomy.
Source control.
Yeah, so source control is very important.
Yeah. I'll tell you one thing about necrotizing fasciitis. It is a very bad organism. As he said, it could be multiple organisms causing it, or it could be group B hemolytic streptococci. Yeah. Don't allow it to go in for necrotizing fasciitis. The best thing is to prevent it or early treatment. Do you understand? Catch them early. Catch them early and do it. And if at all you come across it, debridement, very, very important.
Aggressive debridement.
Aggressive debridement. You will have to remove all that area which is, just cut it off, slough off, get a good debridement. You may have to do it one day, you may have to do it a second day. Step up your antibiotics, send all the tissue for culture. You've got to be very aggressive in your management, otherwise you will lose. Because necrotizing fasciitis, normally it's a very bad outcome. Very, very bad outcome.
That blackening of the tissue that is on a wound is a very dangerous sign. And as Dr. Sunil said, if it had extended beyond the abdominal wound, then uterine, closure itself, maybe you need not have done if she was anyway going to be ventilated.
Absolutely.
You can actually leave the wound open, packed, and ensure that this continuous debridement happens, because the treatment has to be very aggressive.
Very aggressive.
Yeah.
And no, maybe later on you may have to put a mesh. It doesn't matter. At least you've got a life with you, no? The rest of the things you can actually, you don't have to worry about all these small ethical things like, you know, oh, how will the wound look? It doesn't look bad. It'll look ugly. It doesn't matter at all. And another thing, Dr. Nuzhat, have you got anything to say about this? See, they have found a uterine wound dehiscence. And then they have just closed the wound. Do you think that was right, or should something more have been done?
If the source of the infection was the uterus and chorioamnionitis, we could even have proceeded with a hysterectomy.
Hysterectomy. Infection should be knocked off immediately. Aggressive management. And then the patient was put on the ventilator, and whatever you might have done, you have not really done all what should be done. That's how you lost your patient on the 6th post-operative day. Yeah, thank you all so much for that valuable suggestion.
I just want Sunil to clarify two things. When does the sepsis bundle commence in this case? When is the 0 hour?
0 day.
And what is the sepsis package of investigations? It's handy to have such packages so you don't miss out on any tests. So you want to maybe elaborate on that.
Basically, when you have a patient like this, yes, there are something known as sepsis biomarkers that we have not discussed. Yes, we have discussed about lactate, we have discussed about WBC count, we have discussed about, we have not discussed about CRP and procalcitonin. So basically, procalcitonin is one biomarker of sepsis which generally denotes bacterial infection, and galactomannan is a biomarker for fungal infections, which is quite rare in pregnancy, but just have to keep in mind. So we can do this investigation so that we know the intensity of sepsis. If the procalcitonin levels are way back more than 10 and more than 11 or more than 15, then it indicates it's a fulminant sepsis, and you need to be on a war footing. One more thing which in this case, like of course most of the hospitals currently are NAH accredited and other things, but many a times when such fulminant sepsis happens, review your sterilization protocol in the hospital. The CSSD sets that are coming, are they properly sterilized? Because many a times when you have these necrotizing fasciitis, ascending infections, without any, like in this case, of course, there was PROM of 5 days duration, but if you don't have any other thing, review your CSSD protocols, which are very, very important, pertinent, so that you give the best care to the hospital, to the patient.
But Dr. Sunil, you didn't answer what Dr. Kameswari asked you.
Yeah,
when does the 0 hour for 1 hour begin?
In this case, the 0 day itself, the 5 days of PROM, we should have just sent the WBC count, the CRP, the procalcitonin, and even, like, suppose if the WBC count was elevated in this case, at least high vaginal soap could have been sent. And if the WBC count was high, appropriately started off with at least 2 antibiotics, anaerobic plus wide spectrum cephalosporin like ceftriaxone sodium or cefatoxime instead of regular Supacef that we give for elective sections. So basically, that is one thing. And blood gases, yes, lactate is very important. That is the investigation. If you ask me, the investigation in sepsis is lactate and blood gases.
Yeah, ABG is very important. So actually, even if you don't have access to ABG, at least as he said, you can do these following investigations. Do her counts. So simple. You can do a CRP. Though it is a very glorified thing, still CRP has got its value. Then you can ask, if you have got access to procalcitonin, nothing like that. Procalcitonin, now supposing we said, no, many things can mimic sepsis. Now, when you do not know whether it is sepsis, just do a procalcitonin. If the procalcitonin value becomes more than 10, it is bacterial sepsis. You understand? So you know that this is not due to hypovolemia, due to this or that. You know it is due to bacterial sepsis.
Procalcitonin is also elevated in pancreatitis and other inflammatory, like amniotic fluid embolism. But yes, not in pulmonary embolism and cardiogenic shock.
Yeah, but normally procalcitonin tells you it's a bacterial sepsis. So these are all things which you can do other than, then of course, as Dr. Nuzhat was saying, ask for a scan. Don't simply just go and give blood and think blood is the end all of everything. No, it's not.
Also, Sareena, if it is, if it's a smaller setup, even if you're a well-equipped smaller setup, I think this woman was transferred very late. She should have been transferred out maybe on day 2 itself, anticipating that she can deteriorate. I think in sometimes we hold on to the patient in the hope that with an escalation of antibiotic, she will, get better, and that delay can cost her her life.
No, I just wanted to add that when she develops fever, that is the time we should regard it as the golden hour. I mean, I can understand Sunil sir saying that, on day 0 we should have had.
And especially after that 5 days of PPROM, right? Okay.
The minute you get a temperature of 100.4 and above, that is our 0 hour. From there onwards, basically we would call it a sepsis profile in our hospital. We would do a hemogram, a complete urine examination, urine culture, smear for MP and, NS1 antigen in case if we did not have a cause or something. But we would also add SGPT and lactate into it. That would give you an idea whether the organs are involved or not. Unless we send these investigations, neither will we be able to do SOFA score, or neither will we be able to have any kind of sequential scoring system.
Yeah.
I think more than that, they should review their PROM protocol. Each hospital will have its own protocol. If you want to give conservative management, how are you going to follow this woman that she's not developing infection? So that should be in place. Maybe we should start from basics and
all what Dr. Tony
place.
told us yesterday, no? You were not there yesterday. He was telling us when you prolong latency, how to give the antibiotic cover. You remember that? Okay. So we'll go to this. I just wanted to tell you all, there's something called a surgical SSI. This is just infection of the superficial and the deep skin incision within 1 month after surgery. Okay, within 1 month. So we just call that an SSI. That is nothing much. You can do a small debridement of that area, whichever it is, or let out the fluid collection. All that is all small things. But of course, if it's an implant, it is defined as within 1 year. These are the SSIs, the superficial incision. Up to the subcutaneous, it is superficial. You call it deep incisional SSI when it is involved the fascia and the muscle. And then organ space SSI when it is into the intraperitoneal structures, okay? Right. So there's also a surgical wound classification, class 1 when it's uninfected wound, class 2 when it is a clean, contaminated, when you get into under controlled conditions. Like, we open the genital tract, hysterectomy comes under clean, contaminated, okay? Then a contaminated open fresh wounds and the dirty wounds which have got devitalized tissue. Now, this is what we were saying about the organs, okay? It can affect the lungs. So, when you see a tachypnea, this may be the early evidence that she is going in for sepsis. And then slowly you will find the... Doctor, can you tell us more about ARDS? How do you know that there is ARDS in this patient?
If you look at the organs that are commonly affected, Madam is listed the same order. But many times, yes, lungs is the easily gullible and susceptible organ. And the earliest way to pick up the involvement of lung is tachypnea. So the moment any lady has tachypnea, do a simple pulse oximeter saturation. If the pulse oximeter saturation is less than 92%, that means she is having hypoxemia. And in this case, you start administering oxygen so that our target is to maintain saturation of more than 94%. Despite oxygenation, if the saturations are not maintained, then we need to worry that yes, this is going into something more than a simple lung infection. It could be ARDS. ARDS is nothing but basically it's just that the lung becomes solidified and the parenchyma is almost like a consolidation and there is no air exchange. It's like a solid VQ mismatch. It's a consolidated organ where there is no gas exchange but only perfusion happens. And when only perfusion happens, there's a large VQ shunt that leads to hypoxemia and hypoxia. So basically, ARDS is.
So would you take an X-ray chest at that time?
Yeah, chest X-ray is quite helpful. But again, chest X-ray too early may appear normal because clinical features of ARDS on radiological appears only 24 to 48 hours later.
Okay.
So chest X-ray may not be very indicative initially. But yes, lung ultrasound is a very useful device which all the obstetric units they have. And you just put a curvilinear or linear probe and you can see B lines and C lines on the lung ultrasound, and they are very, very good in picking up. In fact, they appear earlier than X-ray. And yes, if you have a facility, CT scan is a sensitive tool of diagnosing ARDS. Like you must have had an array of patients during COVID who had a CT scan, HRCT chest. So basically, ARDS is a very serious entity because when oxygenation is affected, every other organ in the body is going to be affected, and it's going to be a fulminant downhill course.
Sunil, when we say blood cultures, routinely we are sending, ideally is to send both
Paired.
aerobic and anaerobic.
It is always a paired blood culture, aerobic and anaerobic both, not single blood culture.
Oftentimes only aerobic are sent.
That is true. And then you got the kidney, it can go in for acute tubular necrosis.
So,
At that time it is reversible actually.
Yeah. So if you look at the basic pathophysiology of sepsis, basically it is inflammatory cytokine response where there is a microclotting of all the organs and leading to organ hypoperfusion, organ dysfunction. So in kidney there is acute ischemia causing acute tubular necrosis, or sometimes if it's an overwhelming infection, it can cause cortical necrosis also. And cardiovascular system, if you look at the adaptation that happens in pregnancy during in the cardiovascular system is, you have vasodilatation, you have because of increased nitric oxide, and you have vasodilatation and low systemic oxygenation because of the effect of estradiol on the cardiovascular system. So automatically in pregnancy, the SVR is less, the blood pressure is relatively less. Hence, the reserve to tolerate further hypertension, secondary to toxic insult, secondary to sepsis is very low. So they go into catastrophic hypotension collapse very easily, very immediately. So you have to be very careful. Again, coming to respiratory system, again, if you look at the physiological change in pregnancy, the pregnant woman hyperventilates because of the ingrowing fetus, and importantly, there is respiratory alkalosis. And because of respiratory alkalosis, the kidney excrete more bicarb to maintain the acid-base balance. Correct. And hence, the buffering capacity of the mother is less. So the moment you have slightest hypoperfusion because of sepsis, the mother cannot buffer this extra acid, and they go in for metabolic acidosis very, very easily. So all these physiological changes, if you remember very well, they get totally dysregulated in pregnancy, and they go into organ failure very rapidly, very fulminantly. And if you provide aggressive support, they bounce back also very, very rapidly.
True. And see, cardiovascular system, there could be a hyperdynamic hypertension. CNS, we said that, metabolic encephalopathy. She can go in for a DIC also, this patient. Prolonged paralytic ileus, acute hepatitis. That's why, as Nuzhat was saying, you check out the liver function tests, adrenal glands, acute adrenal insufficiency. So now we'll go to another case. She's a patient, para 1, okay, living 1. She was referred on day 7, post-operative day 7, following a emergency cesarean section done for failure to progress, okay? That is on the 2nd. On the 4th, she had fever spikes, 103, and a high CRP of 106. And then the notes say antibiotics were stepped up to injection Cetri, amikacin, metrogyl. Good. On and off, fever persisted, and the ultrasound, see, they've done an ultrasound. And they have picked up a focal collection of 5.5 into 6 in the pelvis, near the anterior wall of the uterus. And then whenever you do an abdominal ultrasound, you can sometimes pick up a bilateral pleural effusion. So they have picked up that. Her fever persisted, and see what they have done? They have escalated the antibiotics to meropenem. And then she was referred to us, okay? So they have done a lot of good things. The ultrasound and admission was 9.6. It showed that the collection had increased, and there was lower lobe consolidation and a collapse of the right lung. This was on 9th, that means 5 days after that she has been referred. A CECT was suggested, and it shows suggestive of infected uterine wound with dehiscence. So we did an abdominal CECT. Then we noticed that the bilirubin was raised, okay, the SGOT, SGPT, the PT, the INR, the creat. So see, one organ, another organ. So we had done a laparotomy, and on 10/6, that means the next day after admission, we have done a laparotomy, we have done a hysterectomy and abdominal toileting. What Dr. Nuzhat was telling you all, intra-abdominal, there was pelvic collection, there was subinvoluted uterus, 22-week size. A subinvoluted uterus tells you that there is infection with complete wound dehiscence. See, the other case, they just closed and left it. This, the wound dehiscence was there, pus was filling the uterine cavity, and so we have done a hysterectomy. And post-operatively, again, she had one rectus sheath hematoma when we looked after her. On the 3rd day, we just put a needle and we aspirated it. And then she was put on NIV for 3 days. for a lower lobe consolidation with collapse, and she was discharged on the 25th. So she's gone home fine. So there were a lot of good things that were done from, yes, Dr. Kameswari, can you tell us what?
At one point I thought, could there be a foreign body even? But
yeah, must think of that also.
Yeah.
No?
But yes, maybe they should look at their sterilization process. Why did a routine cesarean get such bad sepsis with collection? Whether they left any hematoma or something which got infected, that is another possibility. So meticulous hemostasis is another thing. Whether they gave the antibiotics prior to the induction of the cesarean section, you know, the antibiotic. I don't have that information, whether they have given after the fever started. These are the thoughts.
Yeah.
Also, I mean, I'm just thinking that when you have a woman who's spiking fever, if you go back to the previous slide, she was spiking 103, you have initiated antibiotics, and you see a focal collection, which is most likely pus. Right? I mean, or a hematoma. But there is a focus of infection which is loculated within the uterine cavity or on the anterior wall of the uterus. Escalating to whatever antibiotic it is not going to help until that focus of collection is actually removed.
Yeah.
So I think maybe if that was addressed at that time, what you did 2 days later could have been done. At least an ultrasound-guided aspiration to see is that pus or is that blood.
Certainly.
Because sometimes we escalate thinking the antibiotic will do everything, but the focus of sepsis has to be addressed. Just as the focus of bleed has to be arrested in a circulatory shock.
See, and actually all that is, it was actually, as you said, confined. So when it was confined to one pocket, you could have actually aspirated at that stage.
May
Yes,
I
Dr.
add a few things? Whenever a person in the post-op period develops fever after 48 hours, we have to implicate the procedure as the cause of whatever it is. So if on 4/6 she had fever, maybe that same day they could have escalated, like it's a golden hour, maybe ultrasound also becomes a part of that same assessment. Because, and if the fever persisted 24 hours down the line, they
just
could have
keep
gone
your mic close, Nuzhat.
They could have gone in and drained that collection, because foreign body over here was a major thing.
I fully agree.
5 into 5 centimeters mass, that too in front of the uterus. The first thought that comes to you is this a swab left in place? They could have just dived in and taken it out rather. She survived, but it is also true that she could have gone into septic shock.
Yeah, correct.
Similarly. So maybe all the things were done for her. Maybe it could have been done a little earlier. On 4/6 itself, 5/6, we could have opened her up.
And actually, you must remember, she's a primey. She's got only that one baby.
Yes.
But we were determined that we were not going to leave that uterus. 22 weeks pus pouring, wound dehiscence. Yeah. And so we did the hysterectomy. Yeah. We told them, this is a life-saving procedure. If you don't, otherwise it would have happened like the previous patient.
Few more things that are very important, relevant is we know 5 things that have to be done in 1 hour and so on and so forth. But whenever the patient is behaving like this, where on the 0 day, first day, second day, third day, they're not doing well, we tend to focus only on antibiotics and fluids. But more importantly, you need to focus, see the patient globally. You need to start feeding early. If the patient is, because the GI tract is intact, see that she gets good feed. She's not able to take orally, put a nasogastric tube, but start enteral feeds. Because feeding, mobilization, spirometric exercises, or intermittent NIV prophylactically, because this patient is having sepsis, and so we need to prevent. Because she is bedridden, lungs are invariably going to get consolidated. So prophylactically, we need to start spirometry or give adequate pen relief, prophylactic NIV. All these measures will reduce the morbidity and the recovery is little faster.
Correct, very correct. We'll take on this case. She's a gravida 2-1 abortion, ICSI pregnancy, okay? Twins, DCDA, she was referred at 26 weeks on the 4th. with complaining of bleeding PV. Past history of a hysteroscopic septal resection in a peripheral hospital 6 months before conceiving. So they've done a hysteroscopic septal resection and then ICSI and then she has conceived. Then they've also done a Shirodkar on her at 14 weeks. She was admitted at 32 weeks just for a safe confinement because that 26 weeks they noticed that she was bleeding. And remember, 26 weeks only for a neonatology setup they referred the case, okay? The uterine size at 26 weeks because of the DCDA twin was 32 weeks. F1 and F2 were normal. Bleeding was there was no leak. It was a short cervix. So we told ourselves, probably that cervix, that dilatation must have caused, there was a little bulging of membranes. And then we thought it is 26 weeks, we can still do. RCOG has said you can do an emergency cerclage up to 28 weeks. So we were wondering whether we could do, they have already done a cerclage, should you do a recerclage? But because she was bleeding, we did not attempt. Then the ultrasound showed a U-shaped funneling, but there was a little cervix length left. Then on 16/5, that was how many days after admission? 11 days.
12 days.
12 days. So every day was a bonus day for us because it's only a 26-week ICSI pregnancy, okay? So she developed bleeding and acute pain. So she was actually getting into labor. And then there was fetal tachycardia, 190, 185, both the babies. There was a little foul-smelling discharge. So we thought we have done enough of damage. We thought we better. The counts had gone up. The CRP was high. High vaginal swab showed enterococci, signs of chorioamnionitis. LSCS was done on 16/5 at 28 weeks. We got about 2 weeks more, which was real bonus. And the baby weights were 900 grams and 1 kilogram. There was a focal accreta noted in the upper segment at the fundus at the site of the septal resection. That's okay. We just excised that and sutured it. She had PPH because of this prolonged thing, I think. PPH was treated with oxytocin. We did a uterine artery ligation, high and low ligation, but bleeding continued. So we put some CHO sutures and all that. 2 pints of blood were given. She was actually on a NORAD drip introp. She had already going for little hypotension at that time. SpO2 decreased to 87. You remember, I'll tell you one thing, remember 90 and 95. You don't have to remember 94 because it should be more than 94. More than 95 onwards, good SpO2. If it is less than 90, beware. So this SpO2 was decreased. She was put on NIV, she was put in the MCCU, escalation of antibiotics, low molecular weight, patient improved and both the twins survived. See, by the 12 days of waiting, we were actually doing something very wrong. She was bleeding a little, but then we just took a risk. There was, we got a 901 kilogram. Yes, can you opine on this, Nuzhat?
Dr. Sunil was mentioning that any time when you have hypertension and requiring vasopressors, and that is a classical case, I think, over here. We have chorioamnionitis setting in, and on top of that, you have PPH, and you have a very hypertensive response. So I suppose this case, they acted in time, and they gave vasopressors when it was necessary, gave antibiotics when it was needed, and that's why she did not have much of morbidity.
I also believe, Nuzhat, that you should watch for 5 things when you are trying to conserve on a patient like this. Watch her temperature every day, watch her pulse every day, look out whether any abdominal tenderness. You notice that the day that she said pain, she was actually going for a chorioamnionitis, foul-smelling discharge, and the counts. Okay, these are 5 things you should be doing. And so when we found that the counts had gone up, abdominal tenderness was there, we knew that she was going for foul-smelling. We thought we got a smell, so we took a swab, and we got enterococci. And then we did a section because the babies were so small, we thought we will lose. The chorioamnionitis uterus will not respond to your oxytocin normally. So they normally don't respond to your induction. So we did that. We did not know about this accreta at that time. And then we managed her. But see, we were on the verge. No? Don't you think, Dr. Sunil? We were on the verge. Because during surgery, she has required NORAD drip.
Yeah, so the trend also in the counts, when you're in a conservative management, you can see the trend going up.
Correct, the trend.
But then the temptation is that if she doesn't actually spike a fever or doesn't do anything clinical, and we are just watching the CRP going up a little bit and the count going up a little bit, because in an IVF ICSI situation you're waiting on the babies, sometimes we do push ourselves for a few days more, though we know that it is in the best interest of the mother that we deliver. And the family also at that point puts pressure saying, can't you wait a little bit longer? So I think that is the dilemma that sometimes forces us to go this far, isn't it?
No, but I thought with 26 weeks you won't get it for sure.
No, fair enough. No, I'm just saying.
But it is very dangerous for us.
It is something that you tend to, at 27 or 27 plus 4, there's always the tendency to wait a little bit.
No, but I think you bailed out at the right time.
Correct.
When there were signs of chorioamnionitis, we are doing more harm by waiting than not interfering. So, and also aggressively, you started the NORAD vasopressors. She was already on antibiotics, so I think well managed. I hope the obstetrician survived the wait.
And Dr. Sunil, what have you got to say about NIV? That is just enough, isn't it? Just enough for this patient.
Importantly, when you have a patient who is desaturating, as I said earlier, always target SpO2 of more than 95%. So that is very, very essential, very essential. And there is, like basically, if you are giving high flow oxygen mask, 100% or 90% oxygen, and patient is maintaining 95, no, I'm not happy. Basically, try to give less FiO2 and more of positive pressure. So, non-invasive ventilation is quite safe in pregnancy. Yes, you need to give prokinetics, you need to prevent aspiration. See that whenever you're giving NIV, the patient is always propped up and they are always on prokinetics so that we can minimize the risk of aspiration.
So you don't have to intubate, that's what I wanted to tell you.
There is no need. There is no need.
See, when you give NIV, that is just a mask with positive pressure. Okay, you're not put in, when you intubate, that is, you're doing the conventional ventilation, okay? This is just keeping the mask with positive pressure. So less amount, because with the high flow, you'll have to give 50-60 liters per minute. Whereas this is a less amount of oxygen, but with the positive pressure. That was all that was required, and then she came around. Of course, this was managed by her intensivist. Okay, if you've got time, we'll go through 2 short more cases. Is that okay? Right. So this is a 21-year-old DCDA twins, 32 weeks. She was referred on 19/5 with fever and abdominal pain. On admission, her general condition was fair. The uterine size, because it was twins, it was 38 weeks. The first was breech. And this patient had tenderness over the epigastrium. Okay, she had severe tenderness over the epigastrium. Right and left hypochondrium. This was the area of her pain. And we were wondering what it was. On 19/5, her count 17,000, bilirubin 3, SGOT, SGPT normal. But because it was in the upper abdomen, we did a lipase and amylase. Okay, see, both are grossly raised. The RFT was normal. So LFT was almost kind of normal. RFT was also normal. So this was the pancreas. So the ultrasound was done. It showed a dilated pancreatic head with peripancreatic collection. Pancreatitis was diagnosed. And she was started on conservative management, IV fluids, analgesics, antibiotics, low molecular weight. Gastro consult was done. On 21/5, she had fever, drowsiness, respiratory rate 26, SpO2 80. See, SpO2 80. Counts, it has gone up from 17,000 to 23,000. This is what Dr. Uma was telling about the trend. So resorted to an emergency cesarean on the same day. The first twin was 1.6, second was 1. Both well, and the LICO was clear. Post-operatively, she had signs of ARDS, treated again on oxygen and NIV, okay? And because she was maintaining with NIV, meropenem, chest physio, and post-operative CT showed acute necrotizing pancreatitis. Patient improved and she was discharged after 10 days. Anyone would like to take on this?
So, yes, pancreatitis in pregnancy is always a dangerous combination and has very high mortality, especially if you have pancreatitis with the background of preeclampsia, HELP syndrome or AFLP. It's life-threatening. So in this case, of course, those things are not there, but simple acute pancreatitis, most of the time it is either gallstone or biliary pancreatitis, and luckily in this case there was no gallstone also. Otherwise they may require emergency interventions like ERCP and other things. But more importantly, when you have acute pancreatitis, you all this hyperinflammatory picture, yes, the mother can sometimes go into sepsis. Pancreatitis is a aseptic inflammation of pancreas, there is no infection. But if it goes on, and on for some days, or if you like more than a week, then the secondary infection might set in, and you may have problems. And the antibiotic of choice in pancreatitis is carbapenems, like either imipenem, cilastatin, or meropenem. Your other antibiotics may not penetrate the pancreas. So actually selecting antibiotic is very, very important. And all importantly, supporting all organ functions. Like in this case, because the SATs were low, oxygenation was given by non-invasive ventilation, and antibiotics were given, nutrition was given, so on and so forth. Termination of pregnancy, of course, was done. So,
when is the right time to decide for surgery? It's a double-edged weapon, isn't it?
see, as such, acute pancreatitis per se does not require termination of pregnancy. But yes, when the mother is requiring high organ supports, like the mother is required, like in this case, they went into ARDS, the oxygenation required is increasing, SATs have fallen to 80%, the vasopressor support is increasing, or this thing, then there is imminent fetal demise state. So that is the time that we need to consider the fetal demise is imminent, and we need to salvage the fetus for the sake of mother. Basically, importantly, it's all the interventions should be for the maternal sake, but in this case, you save the fetuses also if there are more than 24 weeks of gestation. So termination of pregnancy should be done in the event of escalating supports, escalating settings of ventilatory parameters, escalating settings of vasopressors, like the requirement of noradine is going on, vasopressin is going on, or adrenaline is also needed, 3 vasopressors are needed to maintain hemodynamics, then that is the time that you need to remove and deliver the baby.
Yeah, actually, important. I want all of you all to remember. In fact, I put this only for that. See, many times patients with pancreatitis have got epigastric pain, and we think it is gastritis. Yeah. That's what I want all of you all to know. See, they have nausea, vomiting, abdominal distension. But one thing I can tell you, that pain in pancreatitis, the patient is distressed. There is no question. And they will have fever, which we do not get with the ordinary gastritis. Do you understand? So it is important that any pregnant woman, I am telling you all, please, we have had a lot of cases of pancreatitis, please do an amylase and lipase. And among the two, lipase is more significant because amylase will go up and it will come down fast. But the lipase will continue to persist. And as you were saying, this patient, we also wanted to conservatively manage her. But look at this, what happened. Her fever went up. She became a little drowsy, we thought. And then her oxygen saturation, then we knew we could not sit on her. See, it is very easy for us to now think back. But at that time, we are also wondering what to do.
So the decision to terminate the pregnancy is very critical. And you need to take into account the different organ functional assessment, like SOFA score and all those things. So in a nutshell, again to summarize, if the ventilatory requirement is going up, despite a good like 100% oxygen, PEEP of 7 or PEEP of 10, she is not maintaining adequate oxygenation. If the PF ratio is not more than 300, if the PO2 is not more than 70, or if the blood pressure is not being maintained despite being on noradrenaline, vasopressin, or she is requiring third inotrope like adrenaline, then there is an indication that we need to terminate the pregnancy. Very,
and as he said, see, after termination, she went in for ARDS, and we had given her NIV, meropenem, probably, as he said, that is the right antibiotic for, that was started not by us, by the critical care, chest physio, etc. And the CT showed an acute necrotizing pancreatitis. About 10% goes in for an acute, many times you might even lose your patient. So the only thing, as you were saying, was just support that patient. Give her painkillers, IV fluids, keep supporting, give her antibiotics and keep supporting her. This is the last case. She's a 28-year-old nulliparous woman referred on day 4 of laparoscopy. She has undergone a laparoscopy as fever, abdominal distension and disorientation. She was referred. She was referred because of that on day 4. Okay? She has had a laparoscopy done outside. And the reason why they did that was because she had a stage 4 endometriosis and they were planning an ART in that center. And then when they did it, they did a cystectomy and some adhesiolysis. And after that, their lab showed deep infiltrating endometriosis like yesterday's cases, I guess. Cysts, right ovary 6 centimeters, left ovary 4. They drained it. And large and small bowel adhesions partially released. They could not release everything. Cystectomy was not done. They could only aspirate. And due to the bowel adhesions, they have written everything in the reference letter. Patient was referred on day 4 of laparoscopy with fever, abdominal distension and disorientation. Now you all know a lot of things when you look at that. On admission, her BP was 80/50. So already the SOFA score comes 2. Okay, abdomen was distended, there was guarding, rigidity. These are all bad signs, bad signs. Guarding, distension is bad. Over and above that, if you've got guarding and rigidity is bad. Ultrasound showed echogenic particulate fluid in the abdomen. CT showed a perf in the sigmoid. This is perforation in the sigmoid. Hemoglobin was 10, total count 17,000. ABG showed metabolic acidosis. We did an emergency laparotomy as soon as we saw that. And just that was a rent, it was closed and a colostomy was done. She had elevated RFT, went up to 5, and then I think she was given dialysis, SIMV mode, oxygenation and ventilation, and she improved after 15 days. So, and you want to tell us anything more?
See, again, hollow viscous perforation is every hour you sit on it, the morbidity or mortality increases by about 5 to 6%. So a day is equal to 20% mortality.
Absolutely.
So it is very, very important that whenever you have distension following surgery, don't take it lightly. Yes, it could be one of the, like paralytic LS could be one of the causes. Back of your mind, remember the ominous things and try to keep an eye on it, keep a vision on it. So the moment paralytic ileus will not cause tachypnea, paralytic ileus will not cause tachycardia. So if you have tachypnea, tachycardia, hypotension, very ominous. Neutropenia, very, very ominous. So you need to see that you have a low threshold to get a CT or straight away, even if it's negative laparotomy, open up because it was a grade for endometriosis and a very possibility that you must have injured the bowel. So you have to keep in mind.
Yeah, and what is I put this only for one message. Okay, the bladder, it doesn't matter. You injure it, even if you injure the ureter, it doesn't matter. At the most, you may have a VVF or a ureteric fistula, right? But a bowel will never forgive you. Never. And as he said, every hour is important. As soon as you think there is a bowel injury, get a CECT done. It will tell you where the injury is. And as soon as you know there's a bowel injury, immediately open up. Because it is said that after 72 hours, you will most of the time lose the patient, whatever you do. The earlier you open up, the earlier you're able to tackle the problem. We had a similar problem just 7-8 days back. It was done in the morning. The surgery was done in the morning and the patient was referred to us. In fact, when we opened up, we did not know what it was. It was late in the evening. And when we opened up the patient, we opened up a massive hemoperitoneum. You know, but as I was doing it, I kept telling myself, where's the smell coming from? Where's the smell coming from? And then I was removing all the clots. You know, it was like an ectopic, lot of clots. It was for a hysterectomy in the morning. It was done in the morning. I removed the clots. I kept removing. Then suddenly I saw something which I was not very comfortable with. I said, call the surgeon. And it was actually a huge rent on the rectum, about 3 centimeters. And through that, it was a growth. So actually what I want to tell you is every case preoperative evaluation is very important. You should never have a surprise on the table as a surgeon. Never have a surprise. You know what I mean? Whatever she's got, you do whatever mode of investigation you want, but diagnose your problems early. Never have a surprise on the table. So they did not know that she had a liver, intestinal mass. Just a vaginal hysterectomy was done. And then all these things happened. You know what I mean? It can happen to anybody, but what I'm just telling you is a bowel should be opened up immediately. Immediately. You won't believe it. It was operated that night. It was done in the morning. We operated that night. I think the surgeons went on till very late in the morning. And after that, next morning, when I went to see her, the endotracheal tube was there and she was trying to talk to me through the tube. She was so good. After such a big rent, such a lot of foul smell, everything, she was so good. That is because less than 24 hours, we did not diagnose preoperatively. We just did a scan. There was massive hemoperitoneum. With that in mind, we opened up. You understand? But I'm just saying that patient, so good. She was so good. We have put a stoma there for a colostomy. Everything was done. But I'm just telling you that the earlier you open up a bowel, that is my only message to you all.
One more thing that is very important in cases like this is, many a times the treating surgeon, obstetrician gynecologist are scared about colostomy and other things. And they just do a direct suturing or they request the surgeon to do suturing and not to do colostomy. That's a sin or that's a crime. So whenever you have a 4-day or 3-day-old perforation, close it, but always do a proximal colostomy or ostomy. It's very important because many a times you do primary suturing, the rent 3 centimeters or 2 centimeters rent, they may again leak again. And that is unpardonable.
I agree with
you. So always do a proximal ostomy, which is very important.
Dr. Sareena, can I add something? I think all post-op problems when we should do a bedside ultrasound, and all obstetricians should be able to pick up free fluid in the abdomen. We should be able to pick up a mass in front of the, wherever our suturing is, or if there is a clot on the side, we should be able to pick it up. And post-cesarean section, there is a kind of a misconception that people think that fluid may be there, but it won't be visible. More than a liter won't be there, that it would show up in the Morrison's pouch. So this is one thing, that just put in a probe and see what is happening inside.
True.
So if I can just add to what Nuzhat said, since we have easy access to the ultrasound, I mean, even as obstetricians, if we are not comfortable, I'm sure the anesthetists or in the team will be comfortable to use the same ultrasound machine. They look at the IVC, they tell you whether there's fluid.
Correct.
Then, as he said, they look at the lung. So, and they can look at the heart and see if there's a strain in the right heart. So there is so much that bedside ultrasound can do that may fast track the management, that we should incorporate it into our protocol so that it is beneficial to the patient.
And I should also say that, when IVC, instead of doing a CVP, who does a CVP now? No, really not in an acute emergency, but you just put an ultrasound and see where the IVC is collapsed. It tells you there's hypovolemia. You understand? So it is important that, I just got this last slide to tell you that prevention, what all can you do? Just this morning, Dr. Nuzhat was saying, what is the percentage? It's 4% chlorhexidine. There are people who give a bath also with that. Hair removal with electric clippers with single-use head. A single dose of cefazolin only for clean cases at the induction of anesthesia. Redosing if the surgery is prolonged more than 3 hours. Blood loss more than 1,500. All this is only for your clean cases. For bad, dirty cases, give your triple antibiotics to cover gram-negative, gram-positive and anaerobic. Skin decontamination, 4% chlorhexidine or 10% povidone. Let it be on for 3 minutes before surgery, and it has gone to show the reduce the load of the resident skin flora with the subsequent reduction in the incidence of SSI. Let it stop with an SSI and let it not go on to sepsis.